Next, we have our distinguished panel talking about complex shoulder instability. Sometimes the scope just won't do, and I hate the French. Moderating is Mark Lazarus. We've got Frank Cordasco, our ASCS president, Matt Ramsey, my senior partner, Lisa Gallitz, chairman from Sinai, Greg Bennett, back this year, and Albert Lynn, again back this year. Thank you.
Yeah, that's okay. That's okay. He did a great job. He almost sounded sober.
Hey, how are you?
No, I'm fine. This is the hot seat, so. Hi.
Thank God I didn't have to follow Family Feud. Yep. Great. Okay, so these are my disclosures. So Joe asked me to do this session after the smarter person than me that he originally asked backed out, and which is fine with me. But Joe asked me to do an instability session, and he didn't tell me this title. Dude, what's up with this title, man? I mean, I like the French. I mean, these are two of my these are our colleagues, these are our friends. I mean, I'm worried about you, man. You've got this Francophobia going on. I'm just really worried about you. And so I thought that before we talked about glenohumeral instability, we needed to have an intervention. We need to come to the, like, what is this, hate of the French that you have? And so I've been thinking about, how you got here, what caused this, and I'm thinking that maybe as a toddler, you had a really nasty experience with some French toast. Those of us that know you've had many, many nasty experiences with French wine. I'm thinking that, maybe the night before you came up with this title, you were up all night with indigestion from way too many French fries. And then I thought about it more and more, and I realized I know exactly when this happened. It was that night you got completely blown off by Paris Hilton. So dude, get over it, man. I'm worried about you. Yeah. So I still, by the way, I have no idea what you want me to talk about with that title, so I took moderator privilege and I changed it. So what we're going to talk about is cases that you might consider open surgery for. And this seems to be, things have come around that we seem to be talking about open instability surgery far more than we used to. And so all of these cases are going to be cases that open surgery might be a consideration. For those of you still awake, that is not Albert Lynn. So April couldn't be with us, but we're happy to have Albert. Thank you, Albert. Greg Bennett, Frank Cordasco, Lisa Gallitz, and my partner, Matt Ramsey. So they say when you're playing poker, if you can't see the chump at the table, it's probably you. And I'm looking to my right, and I can't see anyone that's the chump here other than me. So we are not going to do stump the chump here. And in fact, we're going to do things completely differently. I'm going to give you the cases. This is what we're going to be talking about. So we're going to talk about a young male collision athlete. We're going to talk about a critical glenoid bone loss case, instability in a seizure patient, posterior instability, combination instability and arthritis, and Ehlers-Danlos. And so the reason I'm doing it this way is because this is really an amazing panel, and I thank you guys for lending me these people. And I'm not going to spend time asking Lisa Gallitz, what does she see in an X-ray? We don't have time for that. And so what I really want to get at is the thought process in managing these patients and what each one of you, how you approach this and the things that go through your mind, particularly in terms of open versus arthroscopic. So this is a 20-year-old right-hand dominant scholarship junior lacrosse player. He had his first glenohumeral instability event 9 months before, of course, playing lacrosse. This was self-reduced after a minute. He has had more than 6 instability events. They all occur with his arm abducted, externally rotated. They are all self-reduced within a minute. He presents in August. He's a rising junior. He has no problems between instability events. He has no history of instability of his other shoulder. So on exam, he's got anterior apprehension. only with his arm at 90 degrees of abduction, not any lower. He has a 1 centimeter sulcus sign with complete elimination with external rotation. He has some painless subluxation and reduction on jerk test, but he has no apprehension in the anterior direction. And so, Lisa, you're sitting closer. Let's start with you. You know, we teach the residents, we teach the fellows to get a history and to talk about all these things, but how much does this help you in decision making? Specifically, the fact that he never needed an emergency room reduction, does that lead you in a direction? The number of instability events, young male collision athlete, and the fact that it's August and he's a lacrosse player.
Yeah, I think it does help, and some of these things make a big difference. So the fact that he had no emergency room reduction means it was probably perched, it wasn't locked out the front. So that's a positive thing, and he probably has less plastic stretching of the ligaments. But the one thing is the number of instability events. So about, I don't know how many years ago, but there was a study, I think, and Ty Lee was the basic scientist on the study, and he did it with the Pitt group. And they looked at the amount of energy that it took to dislocate a shoulder. And for the first 3 times it dislocated, it was pretty steady. So it took a lot of energy to dislocate that shoulder. But after 3 times, the line dropped, so almost to 0. So there seems to be a threshold and so much stretching that soft tissue can take. Now, it was a cadaveric study, and of course, you know, in human beings, it's a little bit different. But that always, it was pretty striking, and I've kind of paid attention to that as I've evaluated patients, and I think that holds true somewhat. You know, it's not a hard number, but there are a certain number of instability events after which it's pretty apparent that they're going to continue to be unstable. So having 6 instability events, I think, is significant. But it's August and he's about to start playing. So this at least gives you an idea of, you know, how to counsel patients. But he's probably going to come out again.
Albert, what do you think of this? You see this all the time, these kids that are obviously recurrent traumatic anterior, but then you do a jerk test, they subluxate, it doesn't seem to bother them, they clearly subluxate 50% and go back in. Does that change your approach? Is that alone, does that change your approach to this kid?
So, you know, some of the studies actually that we have been doing at Pitt biomechanically looking at this, even after a first dislocation, there's actually a lot of stretch injury to the posterior capsule, and many of these will present with posterior labral extension as well. So I think it could be relevant in the fact that if you're deciding to do something soft tissue, you have to address that component of it. This is just not an anterior injury or pathology. And so, you know, I think from a physical exam and symptomatic or symptom standpoint, it probably isn't sort of his main problem, but eventually if he requires stabilization, I think that is particularly relevant.
So these are his radiographs, and again, I want to go through this so we can get to as many cases as possible, but you know, clearly Hill-Sachs lesion and some glenoid deformity here. So Matt, being your partner, I know the answer to this, but would you get any special views? Like where are you on things like West Point view, and what advanced imaging would you order for this kid at this point?
I mean, you can get West Point views. I mean, honestly, in our practice, our X-ray imaging is pretty inconsistent. So, I mean, if you can train people to get special views, they can be helpful. To me, I mean, I go pretty quickly, especially when there is evidence radiographically for bone loss or bone injury in this case, to advanced imaging. CT scan for me would be.
So your choice would be for this kid would be a CT scan.
Yeah.
So Frank, this is how they always come in for me. They come in already with the MR arthrogram. And so for you, are you comfortable judging the amount of bone loss from an MRI, or would you, in addition to the MRI that this kid got, get a CT scan?
I would agree with Matt. I typically get a 3D CT with this history in this patient population.
So you would get it even though he's already come in with the MRI. You're not comfortable with this alone.
I would say that it's not that I'm not comfortable with it, but in general, I would have seen him initially and obtained the 3D CT. With the MRI, I would add the 3D CT.
But this does give you valuable information. You know, to Albert's point, you know, when you have some of these labral tears that extend posteriorly in a contact athlete, it might change your approach to how you manage this surgically. So, I mean, there is valuable information here, but CT will give you better bony detailing.
Show of hands, whose primary imaging study would be MR arthrogram for this kid? And who's getting a CT as their primary? So actually about half, 50-50, kind of interesting. So he did get a CT, and you can see the obvious bony bank heart lesion. And so measuring this comes out to be 17%. Anybody have any issues with the way I've drawn these lines? Nobody? Abood, not even you? Do we call this, Lisa, does this fit under your description of what we call subcritical bone loss? Like what is critical bone loss? What is subcritical bone loss?
You know, there's a couple different methods that are described to measure this, and technically, you know, it is critical bone loss at this point. But I think really it's always a judgment call. It depends on where it's healed and if it's healed, and how symptomatic the patient is. But it's concerning, definitely concerning.
So is there a number that you, if I say just to the whole panel, who thinks 15% would be considered critical bone loss? 20%. So 20% seems to be, most hands go up. How about the audience? Anybody think 15% is critical? Couple of hands. 20?
Laz, it does
Mark?
depend a little bit, too, about what's going on the humeral side, too.
We're going to get there, Rambo.
right.
We're going to get there. All right.
I'm a good straight man.
All right.
So
So
Mark-
we are.
Mark, just
we-
one
yeah,
other
please.
comment,
Yeah,
Mark?
absolutely.
You know, I think there is some data to suggest that it's less than 15%. So JT's paper, for example, 13.5%.
13, right.
And as Matt just mentioned, I think bipolar bone loss, as pointed out by Arciero's group and UConn, is pretty critical as well.
So, all right, we're all friends here. Who routinely on their traumatic instability patients measures the glenoid tract? Yeah, it's something that we tend to talk about in meetings a lot, but you know, honestly, if I didn't have residents and fellows doing it, I'm not sure that I would be routinely doing it. When I'm in the office seeing patients alone, I don't do it. We do it as part of preoperative planning. And sometimes, you know, we actually did a study on this, which somebody beat us to it, but, you know, it really depends on how you measure it and where you measure it. I mean, I could make this look on track or off track, even with this glenoid, depending on how I measure the defect. And so, and you know, so I think we're up to you, Albert. What do you, you know, we don't talk about Hill-Sachs shape and depth and orientation, things that it's hard to really judge with a glenoid tract measurement.
Yeah, so I mean, I think the glenoid tract concept is, in this case in particular, as Pat was just saying, is pretty important just because, you know, I mean, it's sort of in this region of bone loss on the glenoid where that's just enough for a Hill-Sachs to be relevant. And so the Hill-Sachs shape and depth, I think it's pretty much, I don't know if it's so much sort of how large the defect or how deep the defect is. It's pretty much where it is medial to the cuff insertion. And so even if you have a shallow Hill-Sachs, but it goes very, very medial, I think that's a much different scenario than a very deep defect that's lateral. So that's going to take you from an on-track to an off-track. And I think that is relevant. So I don't think the depth of it really matters.
So Greg, I'm going to bring you in. So what do you think about non-operative treatment for this kid? And you know, recognize that it's August. Should we let this kid try and get through his spring lacrosse season and then fix him, or should we fix him now? And what would you do to try and get him through?
Well, we know statistically the odds are against conservative management for this patient, but where I think rehab maybe fails the physicians in the room is failure to address two things in particular. One is the endurance of the muscle, which has been shown in a number of studies to be inadequate. And when I say the muscle, I don't mean just posterior cuff or whatever it is that happens to be addressed. And the other is proprioceptive sense. And if you read Morrison's studies, a number of different packages there. And that's not something we can correct in short-term clinically. That's got to be someone working with that patient a couple times a day on the sports field in this particular case and really helping them learn about it. But we know statistically, again, this is probably going to be operative. So preoperatively, we want to do all the usual stuff you guys see, cuff and core, and we've added scapula in the last few years and woken up on that some, as you know, but it's much more detailed now in an approach to that. And then we have a good functioning muscle group postoperatively, hopefully for you guys.
So, all right, I think, Matt, we're up to you. So let's assume that, just for the sake of argument, this kid has no bone loss. So we have a recurrent traumatic anterior instability case. He's got a pure soft tissue Bankart, but he's a young male collision athlete. What would you do for this kid? Everything else is the same except he has no bone loss.
Well, again, it would depend a little bit on the MR imaging. It looked, and that wasn't the right sequence or the right cuts to look at it, but it did look like there was a posterior extension of the Bankart. You know, the argument is, do you do this open or arthroscopically?
That's
you know,
better way of what I'm asking.
yeah, and there's
Right.
been a lot of growing kind of movement back towards open in this kind of patient. That being said, you don't, from an open standpoint, I mean, you can shift the tissue open from the front, but if you want to repair the labrum that far posterior, if it goes around maybe to 7 or 8 o'clock, you're not going to get there open. And so this would be the kind of patient where, you know, I tend to do most of my isolated anterior instability arthroscopically beach chair, but this is one where I found that lateral decubitus allows you much better access to the back. You can more circumferentially address it, and also deal, again, to the point where after a certain period, a certain number of dislocations, there's going to be some plastic deformation of the soft tissues. You can address that, I think, better in the lateral decubitus position.
So your primary reason, so would you have you done an open Bankart in the last year?
In the last year, no.
Who's done an open Bankart in the last year? Who's done more than 5 open Bankarts in the last year?
In the last year.
Okay, Anna. Interesting. Okay, good. So the fact that this kid's a collision athlete does not drive you to do him open simply by that fact alone.
Well, if it was an isolated anterior lesion in a contact athlete, yeah, I would probably consider it and probably would do it. But if you think, I mean, you know, the goal of any surgical procedure is to correct the anatomic or the pathologic lesion. And, you know, Tony has done some studies, Rachel Frank has done this work looking at the unaddressed posterior labral pathology and how it affects recurrence. So unless you plan on doing a combined anterior-posterior approach open, if there is posterior extension, I would do that arthroscopically, acknowledging, you know, the argument for open surgery. If I knew based on my imaging that it was an isolated anterior, then I would probably strongly consider a subscap split open Bankart repair.
So Frank, let's now take this kid with the 17% glenoid bone loss, the Hill-Sachs lesion. What would you do for this kid?
Before we get to that, if I can just follow up on Matt's comment, I think it's pretty compelling that under the age of 20 or under, with 7 instability episodes, which is what he's had even though he's not had a frank dislocation, the failure rate with arthroscopic stabilization for all comers in that group is very high and unacceptable in most cases. And there's also a follow-up to that in that if you have more than one preoperative dislocation in this age group, 20 and under, in a collision athlete, your best shot at arthroscopic stabilization is at that point in time. As soon as they have a second instability episode, the failure rate goes up. This young man, given everything you've posed to us or presented to us thus far, I sort of look at it more from a gestalt. Is it more of a capsular issue, or is it more of a kind of a unidirectional labral issue? The full circle concept is not new. It goes back to Russ Warren many years ago. So in this particular young man, now with the addition of not assuming no bone loss, but looking at it as you presented it, you know, the concern is, can an open stabilization, will that suffice, or do you need to augment the bone? And I think in this case, I would err towards a Latarjet or a bone augmentation procedure with 17%.
Okay, so let's, all right, so how about, who's going to do an arthroscopic Bankart repair? Just show of hands, plus or minus remplissage.
And we're assuming bone loss now?
We're assuming this kid now,
Okay,
kid, with that MRI, with this patient. Okay, all right, so who's going to do an open Bankart? And do you ever combine that with a remplissage? Do you do an arthroscopic remplissage and then open? No, okay. Who's doing a Latarjet? Who's doing an arthroscopic Latarjet? No, Charlie Gett's not here, right? Okay. Anybody for anything more significant? Distal tibial allograft? Tony's not here? Good. So, okay. I have. It's, let me go through this and then I'll answer that question. So this is his exam under anesthesia. So he subluxates posteriorly like he did open, but then when I bring him, so he subluxates posteriorly on jerk test. He's got a normal sulcus sign, and I think that, I just want to go back through it again. I'm sorry because Jack interrupted me, sorry. But he's out anteriorly, and it takes me all the way to get almost a full flexion before he reduces. All right, so does that change anything? Back to you, Lisa. Does that change anything?
Well, I was in the group that would do a Latarjet, so it even more solidifies my thought that that's a good idea.
And you don't worry about the posterior, the fact that this kid had a subluxation reduction on jerk testing. He's completely asymptomatic posteriorly.
No, because I think after a Latarjet and surgery, he's going to get a little bit stiff anyway, so I'm not so worried about that.
What's his position again?
I'm sorry? He's a midfielder.
Midfield,
This is non-dominant arm. In answer to your question, I've done distal clavicle a couple of times, and every time I did, so using distal clavicle, autologous distal clavicle, presumably you have some cartilage. Every time I've done it, even in a 20-year-old, the cartilage wasn't normal. I don't know if you've done it, but the cartilage wasn't normal. So that got me away from it. Yeah, Jerry?
It looked to me like on that CAT scan that there was actually a malunited glenoid rim fragment that was still pretty decent size. I think I would have probably done this arthroscopically, osteotomized that fragment, moved it back up and fixed it, and then addressed anything in the back through the arthrosurgery.
Can we save that comment? All right. All right. So this is his Hill-Sachs lesion, and just like Albert said, it's a relatively shallow but broad, and I could not get it to engage, but it almost engaged. So the question is, Albert, does almost engaging count? I mean, obviously, the thing engaged at some point, right? Because I just dislocated the kid in an exam under anesthesia, which means it engaged, right? So.
Yeah, here I think your EUA here is much more valuable than your diagnostic scope here. I'm sure if you push the shoulder far enough, you can get that to eventually engage, obviously, because you were able to do that before you stuck the scope in. So I think your EUA is much more telling here than the scope image. And again, I think seeing that, I think it pushes definitely, to go to Frank's point, what is the gestalt here? Is this a soft tissue or bony issue? This seems to me like more obvious for a bony problem.
So this is looking from the anterior superior portal. It's a beach chair position. So that's his fragment, and that's his labrum attached to the fragment. That's his glenoid rim, and he's got about as much bone loss arthroscopically as you would expect. And Jerry, you and I almost never agree, and I did exactly what you just said. So I osteotomized the fragment and brought it up with my Bankart repair. And then I don't want to go through remplissage, but I did a remplissage also. So hey, Matt, are there arthroscopic techniques that we can use other than mobilizing the fragment? Are there soft tissue techniques that we can use that can consistently make up for bone loss, like placing the labrum up on the face? I want to see if I can get back to that. So sort of this whole idea of creating a bumper, double row repairs, over tightening the anterior capsule, shifting, even rotator interval imbrication. Can we do things with the soft tissue to make up for bone loss?
Well, no, if you're in a critical bone loss, no. I mean, Burkhart's data and tons of other studies have said that you can't. Your recurrence rates are too high. And advancing the labrum kind of, onto the glenoid face in a deficient situation isn't adequate. So no, if your problem is critical bone loss, soft tissue will not, I don't think, manage that. And the literature supports that.
Yeah, Elisa?
So I think, if it was a different person, an average everyday person, a recreational athlete, someone in their 20s or late 20s or 30s, I would have done exactly what you just did. I think what pushes my decision is the fact that he is, such an active athlete and has had that number of dislocations. So I don't I mean, this is a good operation and a great thing to do, but I think who you're operating on makes a difference for me.
Yeah, this is obviously, this kid was like 3 visits and a phone call with the family, right? Talking about Lazarus versus this, right? So this, I'm presenting him exactly for that reason.
Were you, I mean, obviously you were, but were you happy with the quality of the bone on that fragment after you osteotomized it? I think that's, to me, you know, even the non-healed bony Bankarts are this was healed, it's immediately healed, so presumably it's seeing load and it's probably okay.
Yeah, it's hard, essentially what it ends up being is like bone inside tissue, so you get a little osseous repair. I don't think it's reconstructing.
Yeah, but the
glenoid
difference
as much.
is that your labrum is attached to
Right.
that fragment, so that, the one argument I make to people about an arthroscopic repair acutely is if you have a bony Bankart lesion, if you can get those to heal anatomically, they're normal, they're good. And I think presumably that's kind of your goal here, is to say, look, if we can reestablish the bony arc of the glenoid and the labrum is attached to that bone and it heals, you should be good.
Yeah, I think seeing a kid acutely is, I mean, if you see them at their first dislocation, they've got that, oh yeah, that's an opportunity to make the kid whole, right?
Yep.
So,
Yeah.
yeah.
The reason I brought up this sport is that kids who play lacrosse, as you know, if they don't get, doesn't matter how stable they are, if they can't get hyper external rotation to shoot, doesn't matter if they're stable, they won't be able to play anymore.
Well, that was one of the reasons. I don't know about you. You said you did more than 5 open Bankarts. We've heard a lot about open Bankart, right, from this city, right, and from Pagnani, right, and what the literature that came out suggests is that these patients have recurrence rates of 0 and have normal external rotation. Now, I was really happy with the low recurrence rate, and I still am. I still do open Bankart. I'm really happy with the recurrence rate, but I never, ever got no external rotation loss. And so when I present the options to a kid, I talk to him about open Bankart. I said, you will lose some external rotation. Not going to be a lot, but that for a lacrosse player, that could be significant when he shoots. Frank, Albert said something really interesting. He said the depth of the, and I agree, by the way, the depth of the Hill-Sachs doesn't matter, is that how the medial extent, which makes me wonder how remplissage works, right? If we're worried about the medial extent or the central extent into the head, then why are we filling defects from the periphery? We know we don't fill to the medial extent, and so really, how does it work?
That's a great point, Mark, and I'm in particular not a great fan of the remplissage in general. So I may use it in an older patient, like Lisa alluded to, somebody in their 30s or 40s, just to hedge my bets, but in a young athlete, I have not used remplissage. I usually address posterior bone loss on the humeral head from an anterior approach, either with an open stabilization or a bone augmentation procedure. Now, if it's so big that you have to fill it with something, then you're really talking about other options, allografts, et cetera. But I do not use remplissage, despite the fact that it's a rage, in our field right now. It just doesn't make a lot of sense to me.
All right, so let's move on because we've got a few cases I want to get to. So this is a 26-year-old construction worker, numerous dislocations over 5 years, all self-reduced. He's got anterior apprehension both at 90 and 45 degrees of abduction, no posterior or inferior apprehension, normal sulcus, completely eliminates with external rotation, normal deltoid, normal scapula. These are his radiographs, and I don't have his CT, so I'm going to help you. All right, so that's the amount of glenoid bone loss we're dealing with. And this is his diagnostic arthroscopy. So again, looking from the anterior superior portal, and what you can see is he's lost almost a half of his anterior glenoid. So I think, Lisa, we're back to you. What are your thoughts on this? He's 26 years old. He's a construction worker. He's no prior surgery, but he's been dislocating for 5 years.
That is a really large, that's got to be in the critical zone. Just looking at that. But for me, I think it would make a difference. Well, he's dislocated a lot of times, so there wouldn't be a good, healthy bone fragment. When there is a really big bone fragment and you can get a screw or something in that, I think it's worth doing. But if that's attenuated due to multiple dislocations over time, then this would be this would be some type of bone grafting. And is there a size defect?
Yeah,
That's your question, that's too big.
Yeah, that's the question I'm really interested in.
Yeah.
For you, is there a amount, I mean, despite the fact that Joe hates the French, you know, we're all clearly doing Latarjet, and Latarjet works great for the majority of people with bone problems. But in your practice, is there a size of glenoid loss where you say, okay, that's past the point of Latarjet for me?
Yes, and so I think once it gets past that point, and it's hard to say exactly what the percentage is, so honestly, just being honest, for me, it's a bit of a gestalt. I would go to an iliac crest, and then I would repair the capsule to the edge of the native glenoid so that was kind of, I had some soft tissue there, because I don't like to put that against the bone.
And I'm not going to hold you to a number because I agree with you. It is a gestalt, but how do you tell? Do you make measurements on the CT, like the size of the coracoid versus the size of the defect, or is it just a feeling?
I would say for me, once I reach that point, it's between, once I start to approach 25%, a big 20%, that's about where it is for me.
Okay, regardless of what the coracoid looks like on the CT.
Right,
Okay.
regardless. Yeah.
Who does, just a show of hands, who does congruent arc Latarjet versus the traditional? There's a couple. Do you think for the people, anyone on the panel do congruent arc? For the people that raise their hands, do you think that gives you the ability to reconstruct more of the glenoid? Yes? No? Or just a better arc? All right, so I'm interested, let's just go, just numbers alone. We're going to go down the panel. We'll start with you, Frank. What percent of the stability from a Latarjet do you think comes from the bone, and what percent comes from the sling? 50, 75, 25, just...
I'd say the data's all over the map. Personally, I do think the sling helps. I think there is a dynamic component. I think there's a tenodesis effect related to the subscap. And so the problem that I have
You're
with
president of the ASCS. I hate interrupting you, but I want a number. I don't care. You guys are so smart up here that you don't need to discuss the literature at all. I'm interested in what Frank Cardasco thinks.
I'd say 30%.
30% from the sling.
Correct.
Matt?
This is like Price is Right.
Yes.
I'm going to go 40%.
40% from the sling. Albert?
Yeah, I think about 40% for me.
You're supposed to say 41%.
That's right. Lisa? Yeah.
I'm saying 20.
20% from the sling. So everybody up on the panel thinks that the bone is more and far more important than the sling. Is that correct?
Well, there's a triple threat. You've also got the capsular feed.
Right. Who thinks the sling is more important than the bone? Good. Nobody. Okay, good.
No, there was
I
one
think,
person
Mark,
in the back.
it depends on how much bone loss you have, right? Because George Atwell studied this, and once you get beyond 15%, then the bone becomes critical, but under
More important,
15%.
right.
So it matters.
Right, for this case, the bone we would think is more important than the sling, right? If this kid had a large Hill-Sachs lesion as well, do we think that we can fix bipolar bone loss with just an anterior glenoid procedure, regardless of what anterior glenoid procedure we're going to do? Albert?
Yeah, I mean, I think this is the type of thing that calculating sort of on track, off track might help, because if you have, let's say this person has a 40% defect and you take a big chunk of whatever it is, iliac crest bone graft, or take osteotibial allograft, and you kind of calculate what that arc is, you could probably make that arc big enough to not have the Hill-Sachs be a relevant issue. So I think if you restore, if you really restore the entire arc, you might be able to kind of bypass that whole issue with the Hill-Sachs.
Matt, is there a size defect? I don't know if you've done distal tibial allograft. I think you've done distal tibial allograft. I don't know that anybody in our practice has done Tony's glenojet. Is there a size defect that you worry about putting an allograft in because of erosion?
Erosion mean non-healing of the graft?
Or the graft resorbs?
Probably not. I mean, there's an upper limit where anything is going to probably fail, but if you're in the 30 to 40% range, I'd be okay with it. I haven't done it a lot, and it's primarily because of expense. I tend to go to iliac crest for my bone, but I've used it, and I mean, the nice thing about it is it's a big chunk of bone, osteoarticular graft. So, and hemiarticular allografts in general do better than whole articular. I mean, nobody's going to replace the whole glenoid, but they tend to incorporate fairly well, and I think Tony's experience has been relatively good.
Okay. So Frank, I think we're back to you. What do you think? What would you do for this kid?
For this 30-year-old
Yeah, 26 construction worker, yep.
Yeah, I would probably use getting back to you posed a question about the size. So I usually think of a classic Latarjet, the coracoid being about 10 to 12 millimeters in width in terms of what you're going to be placing on the glenoid face. And I think this is probably ambitious, this particular case. The advantage to doing that is it's all autograft. You're not dealing with an allograft, and you have the sling. And for a construction worker, that may be sufficient as opposed to somebody who's going to be really more of a collision athlete. So I'd probably make a decision, game time decision. I'd have a DTA ready, but I might go ahead and consider a classic Latarjet in this setting.
And if the kid had some arthrosis, would that change? Would you go to the DTA then?
Perhaps.
Perhaps allowed. We need Annan. We have a ruling. So I kind of did what Lisa said. I did an iliac crest, but I did it arthroscopic assisted. So that's just harvesting the piece, and this is through the rotator interval, putting the piece in. You can see his articular surface is predominantly okay, but I left the subscap intact. I don't know, anybody in the panel done arthroscopic Latarjet? Yeah, I've had a hard time manipulating the piece with the conjoint attached. And so this just seems to be a lot easier to manipulate the piece. That's the repair down there. And I ended up doing sort of, Lisa said she would put the ligament to the glenoid rim. I actually fixed it to the piece because I was afraid that I was going to tighten him up. So that's fixing.
What did you fix it with?
I fixed it with
Hardware?
anchors to the
screws,
The
yeah.
screws. I used, can we say, Anna, can I say company? I used one of the commercially available arthroscopic Latarjet systems.
Okay, so they were how big, I guess, was my main
They're
question.
4.0, but they are cannulated. They're not
Okay.
great screws. That's I think part of the problem. They are titanium. That's him. Okay, all right. So we don't have a whole lot of time. Let's move on. So all right. So this is an 18-year-old right-hand dominant, Jerry Williams.
Yes,
Genetic defect for Klinefelter syndrome.
no idea.
I knew I could count on you, buddy. All right, so this is an 18-year-old with Klinefelter syndrome. Grand mal seizures every 4 to 6 weeks, this poor kid, despite aggressive medical
that's
management.
Turner's.
He had his first glenohumeral dislocation 6 months prior. His shoulder was dislocated for 2 weeks on that one. 8 subsequent dislocations, all with a seizure. Almost all of them require emergency room reduction. 2 weeks before this, he actually underwent an open reduction through a delta pectoral approach, but they didn't do anything. They just opened him up, reduced him, and closed him. He is not, unfortunately, it's kind of a sad kid. He can't really cooperate for x-rays, so this is all you get. And so obviously, this kid's got something going on here in his glenoid. He's got something going on here in his humeral head. I think we're back to you, Lisa. So, when we talk about, again, you teach residents, you teach fellows, there are classic things we teach them, right? You say, oh, send him to the neurologist and get the seizure under control. How long do we give this kid? Despite all this medical management, he's dislocating every 4 to 6 weeks.
I think you really need to work closely with this neurologist, because if you do a big bone grafting procedure and he seizes post-operatively, he is maybe worse off. So I think that's a very significant consideration. So I would say as long as it takes. And if this kid is having a seizure once a month or once every 6 weeks, that might not be enough time to heal a bone graft. So, and even if he does, he's always at risk, and it's a problem.
I mean, we wrote a paper with Joe Walsh on Latarjets for seizure disorders. There's about a 50% recurrence rate, and the most important risk factor is recurrent seizure. So I completely agree with that. I think this has to be at least 6 months to maybe even a year seizure-free until you do anything, because they can break through anything with a grand mal seizure, and then you have real problems.
What if he's never seizure-free?
Well, then
You
what's the
shouldn't operate.
alternative, right?
Yeah.
So, yeah.
Yeah. We talked a little bit about Latarjet alone for bipolar. So Albert, I'll stick with you. So if you're going to operate on this kid, because of the fact that, look, this kid's going to keep seizing, is more better than less? Like, are you thinking, I'm just going to throw the kitchen sink at this kid? And is there ever an indication for arthrodesis as a primary index procedure?
Yeah, so I guess as a two-part question, I think it depends on sort of how well the seizures are controlled. And if this person never has appropriate seizure control, then you might want to hedge your bets on doing something less rather than more, because it's probably worse to have a failure through something, soft tissue rather than have failure through screws that are just broken in the joint. So if it's truly an uncontrolled seizure patient, I probably would try to do less rather than more, maybe a more soft tissue-based something. This is the type of person you might even consider for historical procedures, such as a putti plat or something to really stiffen this shoulder, because his demands are probably pretty low. Arthrodesis, I think, is certainly an option here, but he's got to be able to heal it too. So if he seizes during that, that's also a major problem as well.
All right, Matt, we're back to you, buddy. Besides send this kid to a boot, what would you do with this kid?
And
Yeah, that's
is the assumption that his seizures are controlled at
No, his
this point?
seizures.
So we're just dealing?
The neurologist has told me that they will never, ever get control of this kid's seizures. They've tried every single thing they know. The kid, by the way, even had surgery. He had some kind of brain surgery for seizure control and still was seizing. They just said they cannot control this kid.
And so do you have a CT scan? I'm just going to,
He won't, the kid, in order to get a CT scan, he'd have to go under general anesthesia.
Okay.
And we couldn't even get him to cooperate for an axillary x-ray. Oh, yeah, sorry, D. Yeah.
What's this kid's function and what's his needs?
His functions are almost none,
He's
and
got Klinefelter, but what's his function?
his functions are almost none, and his needs are to not go to the emergency room every 4 weeks because he's in severe pain when he goes, and it's, so, yeah. Dave, yeah?
So one other option would be to Botox his shoulder girdle. So I had a
that's
patient
actually
like
a great
this
thought.
who we were able to, despite weekly seizures, we were able to keep the shoulder quiet for about 4 months. So that's just
Good
another
idea.
Yeah.
arrow in your.
That's a good idea, yeah.
And what muscles are you cuff and?
Yes.
Well, I mean, you got to put this stuff somewhere.
Everything that they could.
So front and back, pec minor,
Everything.
everything.
Now the young man that we did this on basically came in a sling and had no function whatsoever anyway pre-op, so putting him in, Botoxing his entire shoulder for 3 months, really didn't make one iota of a difference in his, ultimate function. So I don't know in this patient whether, they had a functional arm to be using it for activities of daily life when the patient wasn't unstable. So we may be comparing apples to oranges, but that it would be an option here.
I'm going to skip you, Matt, so we can get to one last case in the last couple of minutes. Can I do one more? Is it, you guys, I still have time for one more? Or, yeah, I'll do it real fast. All right, so I actually did a Latarjet and an osteochondral graft for this kid, and he actually stayed stable. So I mobilized him for 2 months. By the way, spica cast. For 2
How
months.
often did you see him
Yeah,
in
I'm sorry.
follow-up? How often did you see him in follow-up?
Yeah,
Every week?
After the cast came off, I never saw him again.
Oh, really?
All right, so I don't want to waste time because we only have a couple minutes. All right, this kid's 21, had probably an alcohol-related seizure, had bilateral fracture dislocations.
So his seizures are never going to be
but
controlled.
These were reduced, and then without any further alcohol, without any other problems, he's had now several recurrent bilateral posterior dislocations. These all require emergency room reductions, but he's not chronically dislocated. He's never been chronically dislocated. So this is his right. To cut to the chase, he's got a small reverse Hill-Sachs lesion. This is his left. He's got a larger reverse Hill-Sachs lesion, and then this is the CT scan on his left. And so this is the, I don't even care if we get to what I did. This is the slide I want to get to. Frank, we talk about chronic locked posterior dislocation, where we say the reverse Hill-Sachs lesion is all that matters. We talk about recurrent posterior subluxations, like the offensive lineman, where we say the soft tissue is what matters. But we don't really talk much about recurrent traumatic posterior instability. Is this kid analogous to recurrent traumatic anterior instability? Is this just my first case in the opposite direction, or should I be thinking about this kid more like a chronic posterior lock dislocation?
I think the primary issue there is the reverse Hill-Sachs lesion. I think it's predominantly bone at this point, at least as it relates to was it his left shoulder that you showed the last film on? But I don't really understand your question.
Well,
terms
the
of the
question is, this
analogy.
kid, so we talk about, like, if this kid is locked out, right? So he's the alcoholic, and you find him, 2 months later, and he's been dislocated for 2 months. So we know that the big issue is the hip reverse heel sacs, right? This kid's he's never locked out. This kid is recurrent instability. So do I not have to worry about the posterior soft tissues at all for this kid?
I think he's got an engaging lesion anteriorly, and that's the primary issue.
Okay. Everyone agree?
Agree, yeah.
Yeah, so I'll end with this one. I did both. So I did arthroscopic posterior stabilization, and then this is his reverse Hill Sachs lesion on the left, and so this got the left got an open graft for exactly what Frank said, and then for the right, I did an arthroscopic posterior stabilization. The right was a smaller Hill Sachs lesion. By the way, he was grossly unstable posteriorly, both shoulders, to examine under anesthesia. And so this, I was able to elevate the part of it and then oats the rest. Questions? Am I pulling the plug? 225, right? Great, thank you.